Hello and welcome to Everyday Medicine. I'm Dr. Luke and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues, exploring their special interest in medicine and bringing insights, ideas and advice which I hope will be applicable for our medical practices. Our conversation today is with the very energetic and dashing Dr. Michael Fernando. He's an oncologist and he'll discuss with us oncology in general practice. Before starting, however, for Australian audiences, listening does give eligibility for your CPD, so log in and add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, cancer is one of the biggest health challenges worldwide. In 2021, about 15% of all deaths were cancer-related. In Australia, there are approximately 624 cases of cancer per 100,000 people, an incidence which has increased by about 7% over 20 years, with an estimated 43% of people being diagnosed by the age of 85 years. On a positive note, improved oncological medicine and care has reduced mortality by about 25%. This is very reassuring. The top 10 cancers diagnosed in Australia, starting with the most common, are prostate cancer, followed by breast cancer, melanoma, colorectal cancer, lung cancer, non-Hodgkin lymphoma, kidney cancer, pancreatic cancer, thyroid cancer, and uterine cancer. Well, from this group, deaths are more common with lung cancer, followed by colorectal cancer, and then pancreatic and breast cancer. Now, often a primary practitioner will make the diagnosis or suspect changes in his or her patient that leads to a diagnosis being established. And whilst most treatment regimes are initiated by oncologists or radiotherapists, perhaps in conjunction with surgeons, the primary practitioner is frequently saddled with managing many of the day-to-day issues arising from therapy and also the emotional trauma associated with cancer treatment. So I was interested to explore oncology in the sense of general practice more with my colleague and oncologist, Dr. Michael Fernando. And Michael generously joins us today on this podcast. Michael's beginning his journey in medicine. He brings a huge amount of compassion, maturity and enthusiasm with him, as you'll see from his conversation. He's also jointly running a podcast called Oncology for the Inquisitive Mind. This has been very well received and I would strongly recommend it to you. So please welcome Michael to the conversation. Dr. Michael Fernando, thank you for joining me on Everyday Medicine. Michael, it's a great honour for me to welcome you to the podcast and also for me to see you initially as a young trainee and now as a qualified, excellent specialist in oncology, running your own podcasts and really getting back to the society. And it's such a nice thing for me to have you back here, Mike. I remember our first meeting in the emergency department, from the emergency department, then the endoscopy centre at the Valley. It was an interesting case that we got introduced to.
Yes.
We won't talk about that in great detail.
Yes.
But thank you.
No, thank you so much for having me, Luke. It's great to be here. And yes, I do recall that day where you very kindly took a wide-eyed medical student in for a bit of work experience. And no, thank you so much for inviting me on. And I'm very excited to be on the other side of the whole podcast interview dichotomy.
Yeah, well, Mark, I know you tell me, well, I'll just discuss your journey if I can. So take me through, you're an oncologist, you've recently qualified, you're now in the general practice world and forging your own practice. Tell me a little bit about how did you get here? Why oncology? Just run through that and we'll talk about your podcast in a moment too.
Absolutely. So, I mean, oncology, I think, is not one of those specialties that people sort of grow up wanting to. I mean, as a very successful gastroenterologist, Luke, you might be yourself, or you might know people who wanted to do gastro right from the start. I have friends who have wanted to do cardiology or opthal right from the start. Oncology doesn't seem to be that way. But I did my internship in Bendigo in regional Victoria and was very fortunate to have a rotation with the team up there. And not to diss our nephrology colleagues, but I just come from a renal rotation, and I really liked it. I really liked the medicine, but I really struggled with some of the patients, and I'm sure nephrologists will agree they're often quite difficult in terms of getting them to change their behaviours and their risk factors. And then I got onto oncology, and everyone was so motivated, so compliant, so almost enthusiastic to try and kick this awful condition that they've been saddled with, because for most of them, they'd lived a perfectly healthy life, hadn't done anything wrong, hadn't touched a cigarette or drunk to excess. So, and so they were motivated, they were there. And that was really sort of an eye-opening experience for me. And so, potted through BPT, scraped through all of the difficult exams by the skin of my teeth, as it were, and got onto oncology and had a number of rotations around Melbourne. Did a fellowship at the Olivia Newton-John Cancer Centre in head and neck cancer in phase 1 clinical trials, which was fascinating. And and here I am, just sort of that early career phase, which is not what it used to be. It's always a slog, but really enjoy education and speaking about a lot, because an old boss of mine, Phil Parente, who's the head of oncology at the Eastern Health, once said, and I don't think I'll ever forget this, that oncology has basically monopolized the New England Journal of Medicine. I don't think a week goes by where there's not some new oncology study, because there's obviously so much research, so much funding, and so it's always changing. And I think the one thing that every oncologist will say is their job's never boring. It's never monotonous, because you can wake up one morning and all of a sudden something that you've been doing for 5, 10, 15 years, a treatment modality, is suddenly obsolete. And then you've got to sort of start from scratch.
I think we've seen great optimism come into the field of oncology as well, don't you think? I think when I was training, it was there was some breakthrough treatments for leukemia and so forth, but really more recently we've seen some fabulous developments with immunotherapy and what seemed to be untreatable, some forms of melanoma and so forth. Now we're seeing, well, we expect that patient really to do very well long term, and I think that is absolutely fantastic. And I can see the excitement that young physicians have in wanting to become oncologists and be able to offer those treatments. But there's still a big emotional load as well, Michael, isn't there? Because we all have patients that don't do so well. And I wonder how you've managed to steel yourself against the loss, the emotional loss that sometimes comes with getting to know a patient but only finding that they don't pull through. Is that been a difficult journey for you?
It's really hard, but I do like to think of it in a couple of different ways. I mean, for other specialties, when patients don't go, or when patients deteriorate and ultimately pass away, and you can't be a doctor without encountering those patients. It doesn't matter what specialty you're in, with the possible exception of pathology. But the way that patients in oncology usually have that deterioration, and I've got a fusion and amalgamation case that we'll talk about today as the backdrop for oncology and GP. But you can see it coming. You can see it coming. It's often, as you said, the prognosis and survival of virtually every oncology patient has improved, at least to some degree, over the past 5, 10, 15 years, some more than others. But you can see it coming. And a good oncologist, for my money, is one that actually sets expectations early. And so that is part of the journey. And so it's not as much of an emotional lurch as, say, a surgeon who has an intraoperative complication. The patient was healthy 1 minute and then deteriorates the next. Or a cardiologist who has an arrest in the middle of an angiogram. And my cardiology friend has had a number of those. So it's more of an insidious weight, but it is also a real privilege. And it's something that I maintain one of the most important things that we can do, as I said, is do that aspect of things well. It's really hard to have those conversations, especially when you've got someone who's young or healthy and you have to actually say, look, we've run out of options. There's nothing else that we can do. And I hate that phrase, there's nothing that we can do for you, because there's always something, whether it's managing symptoms better or managing, the emotional and family aspect of things better, supporting them better. There's never absolutely nothing that you can do. In terms of how you deal with it, though, that's a very different kettle of fish, because, again, every doctor will have patients who they carry with them. I think that's an inevitability. And it's a real struggle, and especially in sort of private aspects or areas where you feel more intimately involved and more closely involved with those patients, and you're there with them on their journey. It gets really hard when they eventually aren't there anymore. And so advice that I give virtually to any trainee these days is get a psychologist. And I'm not saying that flippantly. I have got a very, very good psychologist that I see regularly. Explore things like Ballant groups, which I sort of, in my mind, liken to AA groups, but for people who have really difficult, medical practitioners who have really difficult cases. Talk about these cases, because if you try and carry them, then you will eventually suffocate under that weight. And, I think that people say to me, oh, you're doing oncology. That must be really sad. And yes, it is, but it's also an incredible privilege to actually be the one that these people look to when they're going through what is undoubtedly the hardest part of their lives.
Yeah. We always have to give hope, don't we? Not unrealistic hope, but hope. Michael, and I can see why you're so popular. You're going to be a very successful oncologist because you've got a wonderful way of talking and sharing these emotions with patients. Tell us a little bit about your approach to oncology in general practice. Like how would we share some of your experiences and tips for people in primary practice? Take us through it.
Yeah, absolutely. So the first thing I will say about oncology in general practice is it's really hard. And my wife's a GP, and I get this a lot, is that, you have patients with these really undifferentiated symptoms and in sort of the lead up to diagnosis. And I can't tell you how many people I've seen who have said, oh, why didn't my GP diagnose this sooner, or why was this missed? And I have to say to them, look, your GP, they see about 30 patients at least per day. It seems like that anyway. And fortunately, only a very small percentage of those will have cancer. And I say to these patients who are understandably upset that, they've gotten to this stage and they're in this stage, if your GP tried cancer every single time someone had an altered bowel movement or, shortness of breath or a headache, then they would actually be a very poor GP, because majority of their patients would be getting unnecessary scans, investigations, blood tests, and for the majority of times that wouldn't yield any results. And so it's really, really hard to sift through when to become concerned. And then when when a patient is on treatment, then it's been my experience that they sometimes come to their oncologist for their sort of general problems more than their GP. And, there are a number of reasons for that. Number one, I will say that oncologists almost by definition are clingy. We like to sort of keep our patients very close to us, and oncologists are usually easier to get into. If you're having chemotherapy every 3 weeks, which is probably a fairly standard interval, you are guaranteed in a lot of places a review every 3 to 6 weeks.
Yes.
I mean, good luck in this day and age getting in to see a GP every 3 to 6 weeks, because they're just
you have to be available, Michael, don't you, for potential complications? You just have to be there. Yeah.
Absolutely. Because otherwise, patients end up in ED, they end up in extremis, and things get very badly. So you have to sort of make those allowances.
Yes.
It's also notable that patients are given a lot of information by oncologists, and some of them are, not as good at tempering or spacing out the avalanche of information, because, we're talking about diagnosis, things that led to diagnosis. Oh, now we're on treatment. Now we're on this treatment. These are the side effects, but you won't get all of the side effects. You'll only get some of them. And so there's a lot of information that's being transmitted, and it's very easy for patients to be overwhelmed. So the first thing I will say, as a sort of a guiding principle for GPs, when you have a patient in front of you who has a diagnosis of cancer, is don't panic. Because the vast majority of stuff that these patients will come to a GP for is pretty much the same as a patient without cancer. Just because you have cancer doesn't make you, doesn't exempt you from all of the other common stuff.
Yes.
And so, look, I might sort of start to frame all of this with this case that I've got, if that's okay.
Yeah, sure, of course. Yes.
It's as I said earlier, it's sort of an amalgamation. I've taken bits and pieces from multiple patients that I've had over the years, but it's a 32-year-old woman, because, those are the ones that really stick with you. And she comes to her GP reporting involuntary weight loss, changes in bowel habit, usually constipation, and she's got a bit of worsening abdominal pain, and she's only had a single isolated episode of blood in her stool. And you do all of the reasonable things. You send her off for an X-ray, you try some appearance, and her symptoms aren't getting better. In fact, they appear to be getting worse. Now, importantly, she doesn't have any family history of cancer. And remember, she's only 32. And, you know, as I said, the hardest thing for a GP is developing this radar of when to be worried, because, you know, if you're worried all the time, you're not going to be a very effective GP. But then if you're completely blind to the possibility that something might be seriously wrong, then things are going to be missed. So the filter that I give to patients, because, you know, as you said, we're getting more and more people who are surviving long-term with their cancer. And so as a result, it's perfectly natural, but every twinge, every bout of nausea, even if it's isolated, every rash, everything becomes, is this my cancer? Is this my cancer coming back, or is this my cancer getting worse? And what I say to these patients is, in general, cancer symptoms don't go away. They might wax and wane, but they never go away completely. And over time, they'll get worse. And so if you have a patient whose symptoms are persistent and they're just not going away, and you're doing all of the usual things, then I think that's a fairly good rule of thumb to have, not necessarily purely for cancer, but that there is something.
Yeah, it's a red flag.
It's not something.
It's a red flag that's it's waving in front of you. Yeah.
Exactly. And of course, we have the other red flag symptoms. In this particular case, unexplained weight loss, yes. Huge red flag. And there's no hard and fast rule of how much weight loss is too much weight loss. And I think the key is that it's involuntary. If someone's saying to you, and I think we all learn this in medical school, you know, if they notice that their clothes size has changed, or people are noticing that, you know, their wardrobe's not fitting as well as it used to, then that is a red flag. And then the episode of the blood in stool, again, always a red flag. Doesn't necessarily mean cancer. I mean, Luke, you can say that probably more definitively than most, but in a young person, blood in stool is always a bit of a worrisome sign. And you might have seen it sort of in the news, because it got a fair bit of news coverage recently. But one thing that I will say in this world that we're living in at the moment is that young age and a lack of family history are not exclusions for having a diagnosis of cancer. This particular lady that has inspired the majority of this case had absolutely no family history. Mm-hmm. And I think we've seen over the past 2 decades, something like a 200% increase in early onset metastatic colorectal cancer. So early onset defined as anyone younger than 50. Mm-hmm. And the honest answer is, and the scary thing is, we don't know why. It's going to be, you know, polygenetic, polyfactorial, multifactorial rather, and but there's no sort of smoking gun. There's no one thing that we can sort of point at and say, yes, that's the reason, let's address that. So just because, you know, it used to be, oh, yes, I've got 3 relatives who have a history of colon cancer, okay, then the likelihood goes up. But that's not really so much the case at the moment. So I guess from our perspective, what is useful in working up the potential patient with cancer. And I mean, you know, there are varying degrees to what this is done. I mean, you know, my father's a GP, former frustrated ED physician. Luke, you obviously had known him for many, many years, but yes. He takes great pride in doing a thorough workup of his patients, and you know, that's the frustrated ED physician in him. But a lot of GPs don't have the time or the resources to do that. So simple things, a comprehensive medical history, and for us, comorbidities, especially renal and liver disease, because that will impact what type of treatment we do, what dosing we do. So having that is very helpful. If you can, Imaging, I mean, that's often how these things are diagnosed on imaging, either incidentally or to investigate a certain symptom. And then, of course, there's a tissue diagnosis. Anyone who's been in hospital will probably have encountered an oncology team that just barks no tissue, no issue at them down the phone. But it is actually important. We don't say that for no reason. And that's because the treatment of different cancers is very, very specialized. And it's very different based on different types of cancer. Before the probably 2000s, early 2010s, we had very few treatments. And so, you could diagnose a cancer on imaging. We'd have the one chemotherapy and we'd say, fine, it's not like it's going to change things. Now the treatment for, say, colorectal cancer is extraordinarily different to that of gastric cancer, even though they're in the same sort of alimentary tract. Leave aside things like breast cancer, melanoma, and what have you. So, but obviously very unreasonable to expect a general practitioner to have the time and the skills to get a tissue diagnosis themselves, unless there's something very sort of cutaneous. So that's why we tend to deal most with our surgical colleagues.
Tell us a little bit about tumour markers, Michael. There's a tendency for us to order these sorts of tests, but they're not particularly helpful diagnostically, are they? Just give us a little feeling about that. Should we be ordering CA 19.9 if we're thinking about bowel? Should we be organising CA 125 and so forth, depending on the circumstance for ovarian cancer? Well, just give us your sort of sense of what's valuable there.
Yeah, no. So I will start by saying there are tumor markers that are valuable. PSA is probably the most common one in general practice. Yes. You don't necessarily need a tissue diagnosis for widespread prostate cancer if you've got a PSA in the hundreds or even the thousands. A lot of oncologists I've worked with would be very happy to start treatment without a definitive tissue diagnosis in that perspective. AFP can be good for both liver cancer, hepatocellular carcinoma, as well as testicular cancer, certain types of testicular cancer, along with beta-HCG. However, the common ones are, as you said, like not good diagnostically. And the reason for that is that the magnitude of elevation does not correlate with a diagnosis. The labs have a normal upper limit, but there's no correlation, or at least none that I'm aware of, between sort of a CEA that's normal versus a CEA that's, 1 or 2 units above normal. Now, if a CEA, again, is 300, then that's pretty definitive. Yeah. But the other complication is that not all cancers of the same type will secrete those tumor markers. I have had people, CA153 for breast cancer, CEA for colorectal cancer. I've had people who are just completely riddled with cancer, and they have normal tumor markers. So it's not a good diagnostic. It's quite good if they are elevated in the first place to track the response to treatment.
Yes.
So, I always say to patients, because the other thing is patients can sort of really cling on to tumor markers as sort of a marker of their progress. And I say a low tumor marker or a normal tumor marker is never a bad thing, but they are not really very good diagnostically, and no oncologist would make treatment decisions, with the possible exception of something like a PSA, purely based on a tumor marker.
Yeah. A normal result does not exclude tumor.
Exactly. And so, my filter tends to be, if I do this blood test, this tumor marker, is it actually going to change what I do? And in the diagnostic workup, the answer is no. If the tumor marker is normal, unless you have a very, very low threshold of suspicion, you're not going to then say, oh, well, I won't refer them to the gastroenterologist. I won't send them for a CT, because just because it's low doesn't mean there's not something wrong.
Yes. Okay. That's helpful. Okay.
So the way I've sort of broken this case down is the the four common stages of a oncology patient's journey. So we had the pre-diagnosis, so the initial presenting symptoms, and now we're going to the during treatment. Because, as you said, Luke, I mean, most of our patients these days, thankfully, are on treatment for years, and they're frequently on multiple different kinds of treatment, all with slightly different side effect profiles, all with different intervals, and it's very complex. So I would never tell a GP, oh, you must know the difference between Folfox and Folfoxiri, as an example. But the main thing is just to have a general understanding of some of the common side effects of systemic therapy. So our patient, JG, she's diagnosed with metastatic colorectal cancer, referred to a medical oncologist, and the oncologist commences her on treatment. As I said before, the initial appointment with a cancer patient is so overwhelming for them. And in my own practice, I'm very, very careful to stop, make sure they have an opportunity to ask questions, but sometimes oncologists are under pressure and they just sort of give them a mountain of information. And the patients feel like, well, I'm with the expert. I've sort of just got to go along with what they say. And that's what happens here. JG sort of is swept up by the situation, but she agrees to treatment. And then she has her first cycle of treatment and she feels awful. She has nausea, vomiting, and she had what she calls an injection in the tummy, which is giving her significant pain in her spine and in her long bones. She can't get in to see her oncologist for another 2 weeks and has no way of contacting them. She can't contact anyone from the hospital to get an answer. And so these patients will frequently reach out to their GP. And it's not really fair to expect the GP to give specialized oncology treatment. That's what we're here for. But there are a couple of things that you can do. And I guess the other quirk to this, and this is unfortunately very common in the public system, is that the GP in this situation has not received any letters or documentation from the oncologist. So they don't know what the hell's going on either. My wife has beaten into me, incidentally, that I must make sure that I send letters very promptly to GPs for all my patients.
It's interesting, isn't it, on that, Michael, because we're in the age of communication, and maybe it behoves not so much the consultant in the public system, but maybe the registrar or the next level down, house officer, just to pick up the phone and make a phone call. They just want to fill you in, this is where we are, it's important diagnosis. It'd be so helpful if people did that and were accountable to that communication.
Absolutely.
I think that does need to improve. It's across all levels of public health, I think, really.
Yeah, and I think, having it written down is obviously very important, and having multiple avenues of communication between the various people. In most public health systems, thankfully, there are a lot of highly skilled nursing staff, specialized nursing staff, allied health staff. And so there are multiple lines of communication. And so I think that really does help. But, absolutely any and all, as much communication as can be put through to GPs is always helpful. So in this particular case, nausea, vomiting, bone pain, what is a GP to do? And my thought is always just go back to first principles. I mean, the tricky thing with oncology, and I guess really any specialty medicine from a GP's perspective, and they have enormous breadth of knowledge, but, significantly less depth, because again, that's the nature of the job. That's their role. And, my wife will know so much more about women's health and pediatrics than me, would not even dream of contradicting her in that area. So first principles. And so specifically with pain, and I'll speak specifically about analgesia for oncology patients in a minute, because I think that's its own special sort of topic, but be aggressive with the analgesia, because cancer pain is a completely different beast to any other pain that you are likely to encounter, because it is unremitting. It is frequently not as responsive to simple analgesia. So that WHO pain pyramid or pain management pyramid, you really need to throw out the window when you're dealing with oncology patients. If you can't get onto the treating oncologist, I mean, I like to think that we're pretty easygoing bunch. And so if you have an oncologist that you're friendly with, I'm sure that they will be willing to help. And the other resource that I recommend to people is EviQ, so eviq.com.au. It's a website run by the New South Wales government, and it has lots of information about most of the treatment regimens that we use. And so as long as your patient can vaguely remember the treatment or the drugs that they're getting, then you'll be able to get a bit more information.
That's very helpful. Yeah.
So I will talk about analgesia management in malignancy, because as I said, it's different and it has its own challenges. So one of the main challenges that I get from patients in this regard is that they're reluctant to take strong pain killers. And it's very reasonable. I mean, there's an opioid epidemic. But what I remind them is that the opioids, OxyContin, oxycodone, morphine, less so morphine, but hydromorphone, they were originally developed specifically for patients with severe unremitting pain conditions in the 80s and 90s. And cancer pain was at the top of that list. And it was really only pharmaceutical greed on the part of these companies, and there are Netflix documentaries galore about this, that led to the epidemic. When you're prescribing oxycodone for a stubbed toe, as an example. But oncology, you should not feel nervous about prescribing opioids in large quantities because, and people worry about addiction, but addiction implies a need for the medication without an underlying need to treat pain. It's a dependence type thing. For these patients, their pain's not going away. And so almost by definition, they're never going to get addicted to the drug because they're taking it for the pain. And so there are components of opioid pain management in malignancy. And I don't know how similar this is to other chronic pain syndromes, but you have a background element, which is your long-acting stuff. So that's your MS-Contin, your OxyContin, your long-acting hydromorphone. And then you have your breakthrough requirements, which is for when that pain spikes. And it will spike, and it will spike to a varying degree every day, but it will spike. And so ideally what you're looking at is when you add up all of the patient's total opioid intake over the course of 24 hours, you want about 2/3 of that total to be background and about 1/3 to be breakthrough. If you're around that proportion, then you can say that the pain is relatively well controlled. As I mentioned, because addiction by definition is less likely for patients with chronic cancer pain, I tend not to worry about a maximum for the opioid medications, but there is a law of diminishing returns. If you're going from 80 milligrams of MS-Contin twice a day to 100 milligrams of MS-Contin twice a day, you're going to have less of an impact on the patient's pain. And in that case, you might want to consider an opioid rotation. And again, different GPs will have different levels of comfort, and that's fine. But if you switch the type of pain control, for example, from morphine to oxycodone or vice versa, then that can often be more effective than just chasing your tail and constantly increasing the dose. So you're keeping them at the same dose, but you're actually improving their pain relief. So now I guess we'll come to the grim part of any sort of advanced cancer patient's journey, and that's the end of life stage. And again, I mentioned this before, but I think this is where doctors of multiple stripes can really, really make an impact. Ultimately, in the advanced setting for the majority of patients, everything we do still is a stall. We're still only trying to delay the inevitable, but we do run out of options eventually. And in this case, it takes 3 years. So JG comes to the end of her life. She's been on 3 lines of standard therapy because she's young. She's also been put through the ringer of clinical trials, and she has become both mentally and physically exhausted. And every patient will have their limit. Some will just incredibly keep going and say, yes, what's the next trial? What's the next drug? I don't care how little benefit it gets me at this point. I just want to keep going. But most people will get to a stage, and the patient who, again, this is based on, she and I did have a conversation where she said, enough is enough. And obviously that's a very difficult conversation for me, but an even more difficult conversation for her. So, keep perspective, I guess, is the other thing. So after a discussion with the family, the patient has decided to forego any further treatment and focus on comfort care. And that is a very important decision to make. And this is where, again, as I said, I hate the phrase, there is nothing more we can do, because there's actually tons that both oncologists, palliative care specialists, and GPs can do. And so from a GP perspective, what can be done for patients in this situation? Because the other thing I will say is some oncology departments at this point will discharge patients from follow-up. And I tend not to necessarily agree with that approach. I can understand it, but I don't agree with it, because from a patient perspective, it would be very easy for them to feel like they've just been abandoned. Oh, we can't give you any more treatment. We're no longer interested, sort of
Doors
thing.
closed.
Yeah, doors closed, exactly. So, go see the palliative care specialist, go see your GP, but we're not too interested. I don't agree with that, but it does happen. So at this part of their journey, patients will often come to you and be more dependent on you than they were before. And so the most important, for my money, the most important thing that you can do is refer to and be available for discussions with the local community palliative care service. These are fantastic organizations that can do a lot of good and really, really help patients in those last phases of life stay out of hospital. Or, if they want, come into hospital without having to go through the rigmarole of going through an emergency department and having blood tests that they don't need, that sort of thing. So referring to, and they're based off geography, so depending on where you are, you will have a different organization, but knowing who they are is very, very useful. Having ongoing in-person and phone appointments with the patient to monitor their symptoms. This is something that I like to do even after a patient is no longer a candidate for treatment, because they might have questions, or their family might have questions. There's going to be a lot of emotional stress in that time. And so anything you can do, I think we owe it to the patient and their family to be available and to help them out. And finally, scripts, extended authority scripts for analgesia. I mean, anyone can go on HPOS through PRODA, and as long as you click the right buttons, you can get as much or as little analgesia scripts as you need, or the patient needs. But you don't want someone who has potentially days or weeks left on Earth to be ferrying themselves back and forth for short-term scripts. And the palliative care organisation will frequently provide advice on crisis medications. So if someone has terminal agitation at home or a pain crisis at home, then the family can have injectable medications that can sort of ease their way. And the community palliative care team will guide you on that. So finally, obviously, we come to the end, and we all end up at this point at some point. But for this particular patient, it came perhaps sooner than we would have liked. So she survived cancer for 3 very, very hard years, but she managed to pass away in the company of her family and in the comfort of her own home. And thanks to, in this case, thanks to, the oncology team, her fantastic GP, and the local palliative care service, she was able to die with dignity and on her own terms. And as I said, it's an incredible privilege to be able to be involved in that. And if I'm going to put a silver lining on a very, very dark cloud, it's actually one of the best parts of cancer. One of the only quote unquote good parts on cancer is that you can actually choose how you spend your last days and how you go out. Whereas if you have sort of a very sudden death, that's not a luxury that you can afford.
That's true. I love your last quote there too, that no one is actually dead until the ripples they caused in the world die away. And I don't know whether you've read a book, Tuesdays with Maury, by Mitch.
No, I haven't.
Yeah. So Maury was a gentleman that had motor neuron disease and died in the United States. He was a lecturer, professor of sociology, and Mitch Applin was one of his students, but sort of, went off, paved his own way in the world, made lots of money, and then saw this guy being interviewed with motor neuron disease and reconnected with him, and has written this beautiful book. And one of the quotes by Maury is that death, it's the end of life, but it's not the end of a relationship. I think that's important for us all to understand. And I often think about patients that I've had that have passed away, and they still, I sort of still see them in the room here with me, and I'm not talking to them and having necessarily a spiritual experience with them, but I think about things that they have said and what they've taught me, the lessons. I think it is a lovely thing for us as doctors to be able to share some of those last moments with patients as well. And as you say, you don't always get to do that, probably in cardiology and other areas where the patients just, they have a collapse at home and they don't really ever say goodbye to anyone. So that's an interesting take on it all.
Yeah, yeah.
That's a beautiful run through. I'm very impressed. I'm thinking about you there, Michael, thinking, gosh, you've got great knowledge, incredible compassion. You're sort of like the template for how an oncologist should be.
Well, thank you,
very
Luke.
sincerely. Michael, I hope actually I don't have to see you professionally.
No, we're on the
Not in a hurry.
on the not so rare occasions that I'm actually able to discharge a patient, I say, look, in the nicest possible way, I hope we never ever get to see you again. They always get a laugh out of that.
You do run your own podcast too, Mark, which has been hugely successful. Tell us a little bit about that, so people listening to this podcast might look you up and be able to sort of share in some of the knowledge and wisdom that other people are, discussing with you. Tell us about that experience.
I do like a good cross-pollination on a podcast, so the short version of it is, yes, I run a podcast with my very good friend and colleague Josh Hurwitz. It's called Oncology for the Inquisitive Mind, and as sort of mentioned at the start, oncology is one of those specialties where the status quo is never fixed. It's always changing, and so for trainees, senior clinicians who need a bit of a refresher, or really anyone who's interested, Josh and I try to bit by bit sort of go through and demystify and put into context the mountains of evidence. And we do it in the same way you eat a whale, which is one bite at a time. So we do one podcast and we might only talk about one or two papers, but if we tried to cover all of oncology research in an afternoon, I mean, that's just impossible. And we really enjoy doing it, and we've had a lot of good feedback for people who sort of say, look, it's really good to listen to, it's really good to learn, and it's really good that you can sort of put things in perspective, because people can read and talk about hazard ratios and stuff all the time, but if you don't sort of know where a particular treatment fits in this grand labyrinth of oncology treatments, then it's really difficult to put into context. I liken it to learning about LFTs as a medical student, having never seen a patient with liver disease. I mean, there's just no context there. So I had no idea what the difference between an ALP and a GGT was. So, it's Oncology for the Inquisitive Mind. It's available on Spotify and Apple Podcasts and multiple other places. I think we've done about 170 or 180 episodes, so there's plenty of content, and we try, unless we're completely exhausted and need a week or two off, we try and release an episode every week.
Yeah, that's a very big effort. I know how long and hard it is to produce.
we need better hobbies, Luke. We don't have too many hobbies aside from this.
Michael, share with me your most sort of influential quote as a final discussion point.
Gosh, influential quote. I think it would have to be. It's not really a well-known quote, I guess, but it is a quote from another patient who similar to what you said, who I sort of think about a fair bit, and a patient who passed away. And the last conversation I had with him, which was only a few days before he died, I was very upset because I really liked this guy. He was an absolutely beautiful human being, and so I was quite upset, probably more upset than he was, because he was that sort of person. And he said, "Michael, don't worry about me. My time is up. What I want from you," and this is a patient talking to me, "what I want from you is to just go out and help someone else like you've helped me." And I've got a little sort of metal token that he and his wife got me, and that goes with me everywhere I go. And every time I look at it, I say, I will try and do good again today.
That's beautiful. Yeah, that's nice, Michael. It's also a testament to how obviously people, feel the same way about you as I do, and in terms of being an excellent doctor and an oncologist. So, Michael, thank you for sharing your wisdom with us today. And, I'll look forward to listening to Oncology for the Inquisitive Mind as well.
Thank you so much for having me, Luke. It's been a real privilege.
Yeah, okay. All the very best. Thank you.
Bye.
Well, thank you for joining me in this conversation with Michael. I really enjoyed his approach to oncology and general practice. And I'm reminded of Mitch Albom's book, Tuesdays with Maury, in which Maury dies from von Gehrig's disease, but says to Mitch, death, it's the end of life, but it's not the end of the relationship. And I think as doctors, we always continue our relationship with our patients through and after death. And we learn from their suffering and their distress and discomfort. I think this makes us better practitioners. So there's always positives to take out of even the most sad and negative parts of our medical experience. Next week, we'll have another very interesting guest, and I'm inviting you to join us during the podcast series. We will be covering a wide range of topics across many specialty interests. The discussions are not intended as specific medical advice for patients, but is general information only and reflect the opinions of the guests interviewed. And if you have a request for a new topic, please email it to us at manager@gihealth.com.au.